Welcome to another EduMed video. Today we'll be focusing on the tracheostomy, and this is the second of the Airway presentations for the Beginner's Guide to Intensive Care. As always, if you like the content, please like and subscribe to the channel and hit the bell notification so that you can see when the next video is up. There's a whole load of things that we'll be covering today on the tracheostomy talk. Tracheostomies are something that a lot of people struggle with because they're relatively uncommon for people to see on the wards, and even in intensive care they're not the most common form of airway, the most common still being the oral endotracheal tube, especially in adults. So we'll talk a little bit about what the tracheostomy is, and then we'll spend a lot of time talking through the different types of tracheostomy. I think this is really important because you'll hear lots of different types of tracheostomy, and I think this is where a lot of the confusion comes as to what different types are and how you manage them. After this talk, I hope that you'll see that actually it's all relatively logical, and there are just a few different types of tracheostomy that you actually need to know about, and a few important things for emergencies. So we'll talk about cuffed and uncuffed tracheostomies, fenestrated versus non-fenestrated, those that have inner cannulas and those that don't have any. And importantly, we'll talk a little bit about the different ways in which you can make a tracheostomy. The surgical tracheostomy, which is done in theatre, usually by an ENT or a max-fax surgeon, compared to the percutaneous tracheostomy, which is done on the unit using a Seldinger technique, similar to that of which you would use to put a central line in. After we've talked about different types of tracheostomy, I think it's quite important just to talk a little bit about the different adjuncts that are used with tracheostomies. The reason this is important is that they're used for weaning, and they do all have little nuances that if you don't know about them, you might well, if you get called in an emergency to the deteriorating patient with that adjunct on, not know that you can't do certain things with them. I think with all of these different types of airways, there should be a daily assessment done by the doctor, and I'll talk a little bit about the different things that you as the junior doctor doing the ward run should make a note of every day when looking at a tracheostomy. This is specifically not a talk about weaning and respiratory weaning specifically. The reason for this is that I'll be going through a lot of ventilation, and then we'll talk a little bit about how you start to wean people after we've talked about the basics of ventilation. The reason I've put this section in is that just so that you get familiar with the wording and the nomenclature people use when talking about tracheostomies, especially when looking at weaning patients off. If you're interested in learning more about weaning, wait till our talks have come out on the basics of ventilation and a little bit more of the advanced stuff on ventilation. And then the two important parts are at the end, which are the troubleshooting of tracheostomies and emergencies with tracheostomies. And again, given the type of tracheostomy, there are nuances to the management of those patients, and we'll highlight all of that in this talk. So you can see there's quite a lot to go through, so let's get started. So, the basics are, what is a tracheostomy? Very simply, it is the same sort of thing as what an oral endotracheal tube is, in that it's a tube that sits in the trachea. The only difference being that instead of it going through the mouth, sitting in the back of the mouth and then going down into the trachea through the vocal cords, this is a tube that we put through the neck, below the level of the vocal cords, and it sits in the trachea. There are different types, as I alluded to, and we'll go through those, but the most common type, and the type that is put in first when a patient gets a tracheostomy, is a cuffed tube. So the cuff, it's very similar to that of the endotracheal tube, and we go through a lot of the details of this in my previous video looking at the endotracheal tube. But suffice to say, the cuff sits in the trachea and occludes the trachea such that no air can pass above the tracheostomy. This is important because the way in which people talk is that air is forced between the vocal cords, and then by moving the vocal cords you can modulate the sound and therefore create a voice. That is not present with a tracheostomy because the air does not get above the level of the tracheostomy and therefore does not go through the vocal cords when the cuff is up. Why put a tracheostomy in at all? Well, the important thing about a tracheostomy is that because it's below the level of the vocal cords and doesn't sit in the mouth, it's a lot more comfortable for patients. It doesn't cause coughing or gagging as the endotracheal tubes do. And therefore you don't need any sedation for the patient to be comfortable with that tube to be in. So you often see tracheostomies being put in for patients who need long-term ventilation, or for those patients who have come to intensive care, spent a huge amount of time in intensive care, and there's an expectation that they're going to spend an even longer period of time needing ventilation or to protect their airway from lots of secretions or other things like persistent reflux. There's been studies looking at the benefit of putting these tracheostomies in early versus late into their intensive care stay, and essentially what they've shown is that there's no real difference, so it doesn't really matter when these tracheostomies are put in, and every unit is slightly different in their policy with regard to when they consider a tracheostomy. Generally speaking, most people start thinking about a tracheostomy between days 7 and 10. However, it can take longer, and patients can be kept with an oral endotracheal tube for weeks, if not months. We try not to do that because the benefit of the tracheostomy is that we can take the sedation off, and therefore we can start weaning the patient. And also, once they don't need ventilation, they can step down to wards which can take tracheostomies, thereby freeing up intensive care beds. The important thing to look at here is how short the tracheostomy is, and therefore there's a lot less dead space. Also, because you're not breathing through a longer tube, there's a lot less resistance, and so patients can spontaneously breathe through these, depending upon the size of it. So let's think a little bit about the different types of tracheostomy. And I think the most fundamental difference and the most important one is looking at those that are cuffed versus uncuffed tubes. Now, when you look at a patient from the front, you will immediately be able to tell which is a cuffed tracheostomy versus an uncuffed tracheostomy. If you remember back to the endotracheal tube video, all cuffs have a pilot balloon that sort of dangles and sits outside. With the endotracheal tube, it's usually a blue pilot tube. In tracheostomies, depending upon the different makes, they can be different colours. Purple or white are the most common, but blue is also seen. The pilot balloon is a little balloon that blows up with an amount of with a pressure of air that's similar to that seen at the cuff, and so it gives a good visual and tactile indication of the amount of air and therefore how inflated the cuff is inside the trachea. If it does not have a pilot balloon, it means that it is an uncuffed tube. This means that you've got the plastic of the endotracheal tube, but there's no plastic cuff that occludes the trachea. So what does that mean? Well, without that cuff, you can still force air in and out through the trachea. However, you're also going to get air escaping around the tracheostomy itself. So if the patient's spontaneously breathing and has got a patent upper airway, i.e. they have not had a laryngectomy, you can get air being entrained through the mouth and down the trachea, as well as through the tracheostomy. Similarly, when the patient's exhaling, you will get air coming out of the tracheostomy and also out through the sides of the tracheostomy. This is important because as you're starting to wean a patient off from the ventilator, you might want to try and get them breathing a lot more for themselves. And if you imagine trying to breathe through a small tracheostomy tube, it's like breathing through a straw. It takes a lot of effort, and therefore, if you use an uncuffed tube or you deflate the cuff of a cuffed tube, what can happen is that it reduces the amount of resistance that the patient has to breathing in and breathing out, and therefore they don't have to work as hard, and so they're able to come off the ventilatory support a lot quicker. Tracheostomies that are uncuffed are generally used for patients with long-term tracheostomies. When you're weaning someone off from a tracheostomy, patients will sometimes have periods of what we call cuff down. What this means is that the nurse will deflate the cuff and then allow the patient to breathe around the tracheostomy. Now obviously this depends very much upon the size of the tracheostomy. If you've got a large tracheostomy, for example a size 9, and if you remember back from my last talk, the numbers are analogous to that of an endotracheal tube. So a size 9 tracheostomy denotes the internal diameter in millimeters of the tube. So a size 9 tube has a 9 millimeter diameter, internal diameter. So it's quite large, will cover a lot of the trachea, and therefore when you bring down the cuff, you might find that there's not a lot of room around that tracheostomy. So often, before patients are trialled on cuff down periods, what the doctors will usually do is exchange the tracheostomy to a slightly smaller one, so a size 8 or a size 7 tube, and so on. This allows more space around the tracheostomy and therefore easier for them to breathe. Not everybody does that, but that's relatively common practice. There's a really important aspect to an uncuffed tracheostomy, and that is if there is an emergency and you need to give positive pressure ventilation to them. If you imagine putting a ventilator onto an uncuffed tracheostomy, you can force air in and out of the tracheostomy tube. However, when you put pressure through the tracheostomy and force air through it, in an uncuffed tracheostomy, the air sometimes will go down into the lungs, but a lot of it will go through the path of least resistance, which is to go around the tracheostomy, up and through the mouth. And therefore, if you do in an emergency have to bag a patient who has an uncuffed tracheostomy, actually what you may need to do is to exchange it for a cuffed one, because by having a cuff, inflating it, you prevent the air from leaking around the tracheostomy and coming out through the mouth. Therefore, all of the pressure that you generate by bagging will be seen by the lungs and allow them to expand. So really important to note when you have an uncuffed tracheostomy, and every patient on an intensive care who does have an uncuffed tracheostomy should have a cuffed one next to their bed, just in case there's an emergency. The other terminology that you'll sometimes hear is the so-called fenestrated tracheostomies. Now, there are different types of fenestrated tracheostomies. Generally speaking, they don't have a cuff, but occasionally they can have a cuff. Now, fenestrated essentially means holes. And what this tracheostomy has is that they have holes above the level of the cuff, if they've got a cuff, or just in the body of the tracheostomy. So why bother having it? Well, the reason is that it increases the flow of air coming out through the mouth. Because now you can see that there's two routes for the air to come out. It can either come out through the center of the tracheostomy, or it can leak out through the side hole that you can see on the right hand picture on the top where it says fenestrated tube. Why is that beneficial? Well, again, if you look at the picture on the left hand side, you can see that when you exhale, imagine you have a hole above the level of the cuff. Now what you're getting is air coming out through the bottom of the tracheostomy, and then it'll escape through the top before it comes out of the end of the tracheostomy, and therefore go up and through the vocal cords. So what you're trying to do is to maximize the amount of air that goes through the vocal cords. As I said before, the way in which you make sound is that you allow air to go through the vocal cords, and then you modulate the frequency of the air by changing the shape of your vocal cords. So fenestrated tubes are really used to try and give patients a voice, and that voice to be as strong as possible by increasing the amount of air that goes through the vocal cords. Now, as I say, most fenestrated tubes are uncuffed, but you can get cuffed ones. Now, an important thing about fenestrated tubes is that if you imagine in an emergency, you need to bag the patient, again you come into the same problem as you would do if you had an uncuffed tube. And that is, if you put the bag onto the tracheostomy and you provide positive pressure ventilation, the air can now escape in two different parts. It can either go through the end of the tracheostomy and into the lungs, or it can escape through the fenestration, go up through the vocal cords and out through the mouth. Generally speaking, air will go through the path of least resistance, and therefore most of it will come out of the mouth. So these patients will need to have either their tracheostomy changed, or some of the cuffed fenestrated tubes actually have an inner cannula, which is something I'll talk about next, which occludes that fenestration and therefore changes it from a fenestrated to an unfenestrated tube. So essentially the fenestration is basically a hole at the upper end of the trachea to allow air to escape out and go through the vocal cords, and it's used to try and strengthen people's voices and to allow them to communicate more easily. Now, as I alluded to, the inner cannula. This is a great little kit, and it's something that comes with the tracheostomy itself. Now, anyone who's managed a tracheostomy knows that they get a lot of secretions, and because you don't get the humidification that you do as you're breathing through the nose, the secretions themselves can harden very quickly, and so you can get a lot of crusting around the inner aspect of a tracheostomy. If you look at the picture on the right hand side, you can see just how much crusting can occur and how it can really narrow the internal diameter of the tracheostomy. As such, what some companies have done is they've provided inner cannulas, so that if it starts getting filled up with debris, with hard secretions, or there's lots of sputum in there, you can unclip and take out the inner cannula, which is the thing that you can see in the middle of the picture on the left hand side, and exchange it with a clean one, and therefore continuously maintain a patent internal diameter to the tracheostomy, and therefore not increase the resistance to breathing. A really important point about these inner cannulas is that not every tracheostomy has an inner cannula, and this is where getting to know your equipment's really important. Generally speaking, most intensive care patients will have a spare tracheostomy by the bedside, just in case the patient accidentally coughs their one out. You can quickly put in another like for like. It's really worth opening up the box and having a look at the spare tracheostomy, because you will see whether it's got an inner cannula or not. It is not uncommon for people to think that there's an inner cannula, try yanking on the end of it and accidentally extubate the patient, because actually that type of tracheostomy did not have an inner cannula at all. So, key point, not all tracheostomies have inner cannulas. If it does have an inner cannula, it'll be obvious. It usually says on the collar of the tracheostomy, but also if you have a look at the pack for the like-for-like tracheostomy next to the patient's bed, you can have a little play and see if they do have this little plastic insert in there. Now, this is the first one of the major warnings that I want to give you with tracheostomies. If you have a tracheostomy, it does connect up to a ventilator, or what you can see here, which is a special type of bag valve ventilator that we use called a water circuit. You'll see them very commonly on intensive care. Essentially, oxygen passes into it, it fills up the green bag, and then you can use that to push air in, and you can adjust the pressure of the amount of air that goes in by the valve that you see in white at the top next to the angle piece. Now, the important thing about tracheostomies with inner cannulas is that this mechanism, this 15mm connector, only fits onto the tracheostomy if you have the inner cannula in. The reason I emphasize this is one of the first reactions when you have a problem with a tracheostomy, say it's blocked with lots of sputum or the patient suddenly desaturates, is that you want to change the inner cannula, because if it's full of lots of secretions and things, you might that might be blocking it off and making it difficult to breathe. However, if you take that inner cannula out, you must put in a new inner cannula. If you do not, the connection for the ventilator tubing or for this water circuit will not connect onto the tracheostomy. So I repeat again, if you take out the inner cannula, you must replace it with another inner cannula. If you do not, then the ventilator tubing may not fit onto the tracheostomy, and you may be put into a situation where you can't actually bag the patient because you haven't got the inner cannula in. So always replace the inner cannula if you're going to take it out. Now, it's worth thinking a little bit about the ways in which a tracheostomy is formed. The reason for this is it slightly changes the way in which you manage them in the first few weeks after they've been put in. In the old days, when I first started training, it was quite uncommon for tracheostomies to be done on intensive care. Pretty much all of them went down to theatre, and in theatre, the surgeons would open up the neck, expose the trachea. You can see here this is actually a tracheal graft that's being put in, but the real trachea looks fairly similar to that. So they open up a big space, find the trachea, and then they make an incision in the trachea itself and then place the tracheostomy in. This means that you've got a good big tract and a wide area, and they suture all the fascias out of the way so that you can form a good stoma, so the trachea is exposed nicely. This is in contrast to how a percutaneous tracheostomy is done, and this is outlined in the picture on the left hand side. Here, what you do is you use a needle to go through the front of the neck and in between usually the second and third or first and second tracheal rings. You puncture it, you pass a wire through the needle and into the trachea, and then you serially dilate the tract from the skin through to the trachea itself, and then you pass the tracheostomy over the wire. Now, the important part of that is, if you imagine you've dilated everything up, all of those tissues can then spring back again. So that tract can close up very quickly if the tracheostomy comes out. And that's important. And so usually for the first 2 weeks after percutaneous tracheostomy has been put in, there is a high risk that tract could close up very quickly if you don't get another tracheostomy in. And also it can be quite difficult to get another tracheostomy in as soon as that comes out. So be very careful of patients with percutaneous tracheostomies for the first 2 weeks, some say up to 4 weeks. Whereas with the surgical tracheostomy, you can still get the same situation. However, it's less likely that you're going to have problems with regards to the stoma itself closing up, just because the surgeons would have sutured a lot of the fascias out the way to keep a nice open stoma. So, the takeaway is, whenever you're taking over a patient with a tracheostomy, always find out whether it's a percutaneous or a surgical tracheostomy, and then always find out how long ago that tracheostomy was done. If it was done in the last 2 weeks, the nurses and yourself need to be very careful about when you're moving the patient or when the patient's coughing, that they don't cough their tracheostomy out, because you may end up losing that tract And if that is the case, if they haven't had a laryngectomy, which for percutaneous tracheostomies they wouldn't have, then always intubate from the top if you need to, and if you can't easily get back into that tract. Now, you will hear about lots of different adjuncts, and lots of adjuncts are used with tracheostomies, specifically to try and improve the ways in which patients are weaned off their tracheostomies. One of the key parts and the problems with having an oral endotracheal tube is that because it's going through the vocal cords, these patients can't talk, which is a shame, and communication is difficult, and if you don't communicate with patients, they can develop delirium after a while, and it can also be frustrating for them not to be able to express their views. As such, the first of the adjuncts that we'll talk about is the so-called Passy Muir valve, also known as a speaking valve. This is a really simple piece of kit. All it is a one-way valve. When you take a breath in, the diaphragm moves in and air can rush in. So you cap the tracheostomy outside with this Passy Muir valve. When the patient breathes in, the air will rush in through the Passy Muir valve, through the tracheostomy and into the lungs. And this is the clever part of it. When the patient tries to breathe out, this diaphragm pushes against the Passy Muir and therefore stops the patient from breathing out through the tracheostomy. So if the patient can't breathe out through the tracheostomy, where will that gas go? Well, if you've deflated the cuff or you've got an uncuffed tube, that gas will therefore go around the tracheostomy, through the vocal cords, and therefore the patient will be able to phonate and that air will come out of their nose or through their mouth. So this is why it works as a speaking valve, but it also highlights the extreme danger of a Passy Muir valve. If you imagine you leave that cuff up, the patient can take a breath in, but now they're breathing against a blockage. The Passy Muir valve closes every time they try to breathe out. If you have got that cuff up, there's nowhere for the air to go. It can't go around the edges of the tracheostomy and out through the mouth. And so what will happen is that each time they take a breath in, they'll get air in, but they can't breathe out. And take another breath in, more air in, but they can't breathe out. So they start to hyper expand. And if they do that, they'll very rapidly deteriorate with an increasing intrathoracic pressure, with increasing carbon dioxide because they can't breathe it out. And it can be very distressing for the patient. So Passy Muir valves can only be put on cuffed tubes when the cuff is down, or with patients who have uncuffed tubes. You can also improve the amount of air that flows through the vocal cords by using it with a fenestrated tube, but you don't need a fenestrated tube. You just need a patient who has a cuff that is down or an uncuffed tracheostomy. There is a lot of resistance breathing through Passy Muir valves, and so patients often need to be fairly strong before they can get to this point. And so, generally speaking, the company says that you shouldn't have the Passy Muir valve on for more than 2 hours at a time, because they can tire fairly quickly with these. As I said again, and I will reiterate this just because I see it every so often, especially with the inexperienced nurses. If you are putting a Passy Muir valve on, you must make sure that the cuff is down if it is a cuffed tube. Otherwise, the patient will just keep sucking in air, and not be able to exhale anything. The tracheostomy button is something that we don't really see that often, but you will see some people doing it. Other people call it capping off the tracheostomy. What this is, in this country, in the UK, we generally tend to use a red one. And what it does is it completely occludes the tracheostomy. Now, obviously, always, this cannot be done in patients who have a cuff that's up, because then there's no air going in, there's no air coming out. Why would you want to block off the tracheostomy? Well, this is where you want the patient to be breathing through the mouth and through the nose. Air goes in through the mouth and nose, into the trachea, and then out through the mouth and nose. So you're basically getting rid of the tracheostomy completely and allowing the patient to breathe normally. This is not done that often. However, the patients for whom this can sometimes be used is those patients with long-term tracheostomies, for whom they actually need it more, for example, if they have lots of problems with secretions, so for subglottic suctioning, or for patients who have sleep apnea, where they don't need their tracheostomy during the day, they just need it overnight when they need to be ventilated. So you might see some people weaning patients and just seeing whether they can cope without the tracheostomy by capping it off. The important thing again is that it is red. If you have a patient who's suddenly deteriorating, always take that red cap off before putting on the water circuit or the ventilator. Because obviously if you try to connect it to it, it probably wouldn't fit, but even if you manage to jam it on, you're not going to be able to get any air through because the whole tracheostomy hole is covered up. Now, if you imagine a tracheostomy and breathing through the tracheostomy, what you've completely got rid of is the nasopharynx and oropharynx of normal breathing. Now, the main thing that the nose does is it humidifies the oxygen that's going through. And so by humidifying the air, what you're doing is the secretions that are there remain moist, supple, and easy to cough out. However, with a tracheostomy, because you're going below the level of the nasopharynx and oropharynx, all you're getting is dry air coming in. So when patients are spontaneously breathing, it's not good for them, and that's why you can often see a lot of crusting and a lot of thick or hard secretions around the tracheostomy. One way in which to avoid that is by using something called a Swedish nose, which you can see on the right hand side of the screen. This is similar to what we call an HME, or humidification and moisture filter. And what it does is it takes the humidity of the breath coming out of the patient, keeps all that moisture and humidity in these little filter areas. They get soaked in water, and so then when the patient takes another breath in, the air gets drawn through this sort of wet hygroscopic material, and then it humidifies it. So the reason it's called Swedish is because it was developed in Sweden, and nose is because it's effectively doing what the nose is doing, i.e. humidifying and heating up the air that the patient's breathing in through their tracheostomy. As such, what they do is they stick it onto the end of the tracheostomy, and so they can breathe in and out. Now, I just want to pause for a second and just talk a little bit about the picture that you see on the left-hand side here. This is an 8.5 millimeter tracheostomy. You can see that because you can see at the top it says ID, internal diameter 8.5. OD stands for the outer diameter. So you can see actually, even though we talk about an 8.5 tube, the outer diameter is actually 12.2 millimeters. So it's actually bigger than the inside, obviously. But what I want to highlight here is that the patients who have tracheostomies with inner cannulas, because the inner cannula takes up some of the space of the internal diameter, can you see on the bottom there it says inner cannula ID 7.5. So even though you've put in an 8.5 millimeter tracheostomy, the actual breathing tube that the patient is breathing through is a 7.5 millimeter internal diameter. So you can see there's a lot of resistance there already. There's a much smaller tube than even you think it is. And then if you add on to that the HME, which does have a very low resistance, so the Swedish nose in this case, it does have a low resistance, but there is still some resistance. So you can see this patient is already having to breathe through a smaller tube with something stuck on the end of it. So there's a lot of resistance to the breathing, and therefore these patients can get tired just continuously being on the Swedish nose. So especially when you've got weak intensive care patients who have been on the unit for long periods of time, it's worth giving them breaks on the ventilator just to let their respiratory muscles rest, especially when you're first starting with the Swedish nose. So often what we do is we put the Swedish nose on for half an hour or an hour and then give them a break on the ventilator and then come back to the Swedish nose, just so that they get a bit of time to rest as well. A lot of weaning units will also allow patients to use these various adjuncts during the day, but overnight when they're sleeping, put them back on the ventilator just so that they give them time to rest and relax, so they're not working hard the whole day and the whole night, which can often push back recovery quite significantly if you push patients too fast, too quickly. Now, as a junior doctor, one of your main roles is going to be to do the daily ward round. And it's really important when you see a tracheostomy that you do a few things as a mental checklist. Some of these things you're not going to be able to answer yourself. Now, the first thing is always to have a look at the tracheostomy. Make sure that there's no crusting around it, there's no infection that's forming, so have a really good look around. Then, once you've done that, you need to ask yourself a few questions. Can they wean? Now, we'll go through a huge amount on ventilation in the following talks. However, if their level of ventilatory support is small, you could start to think about giving them trials of what we call trache mask. This is where you take them off the ventilator, put an oxygen mask over their tracheostomy and let them breathe through the trache. Again, we'll go through a lot more of that in later talks when we talk about ventilation. Then you can think a little bit about, can they tolerate cuff down? You might hear doctors asking, can they tolerate cuff down? What they're talking about is, firstly, do they need a lot of positive pressure to be able to breathe? If you need to be positive pressure ventilated, it means you need the cuff up so that the pressure that's provided goes into the lungs as opposed to escaping through the mouth. However, if they don't need a lot of ventilatory support, they might be able to tolerate the cuff down. However, there are other things to think about. Remember before we talked about a protected airway. Well, an airway is only protected if that cuff is up. So if you've got an uncuffed tracheostomy, counterintuitively, actually you don't have a protected airway because stuff can still go from the oropharynx down round the sides of the tracheostomy and into the lungs. Similarly, if you've got the cuff down, the airway is not protected. So if patients have lots of secretions, especially oral secretions, actually there's a question as to whether they should have the cuff down because they may well develop significant silent aspiration. And it's not uncommon for patients who start having trials of cuff down to then develop ventilator-associated pneumonias because they've just started aspirating silently. Now, if you are bringing the cuff down, what you're saying is that you want the patient to breathe around the tracheostomy. Now, in order to do that, they need to have a small enough tracheostomy that there is space around the trachea and the tracheostomy. So, before you start bringing the cuff down, you might need to downsize the size of the tracheostomy. And that is the theory behind people coming down on the size of the tracheostomy to help with weaning. It's arguably not that important to do that because as long as you've got a patent tracheostomy, the air will come in and out through the combination of both the trache and around the sides of the tracheostomy. So some people don't downsize. However, the vast majority of, certainly the older consultants, tend to downsize early in their weaning period. Now, if you are bringing the cuff down, you must accept the fact that you're increasing the risk of aspiration. That could be silent aspiration of secretions. However, also if a patient starts to vomit, you do not have a protected airway. Yes, you have a tube in the trachea, but you don't have that cuff to protect things from falling down into the lungs. So if someone starts to vomit who does have a tracheostomy with a cuff down, always put that cuff back up. That is the only way to protect them from getting an aspiration. You can also consider whether to put a Passy Muir valve on. Now, in order to put a Passy Muir, to be able to tolerate a Passy Muir valve, they must be able to tolerate cuff down periods. So, If the patient can only tolerate half an hour of cuff down, there's no point in putting a Passy Muir valve on, because you've already increased the resistance through the circuit by having that valve in place. And then on top of that, if you've now got to, the patient's got to breathe harder because they're having to breathe around the tracheostomy, it can be quite difficult for them. Even if they're able to tolerate 24 hours of cuff down, the company that produced the Passy Muir valve suggests that you should only use the Passy Muir valve on the tracheostomy for 2 hours at a time because of that increased resistance in the circuit. Now, all of these things are taken as general rules. You will see on some units where patients have a Passy Muir valve connected to a ventilator that provides a little bit of additional positive pressure ventilation whilst they've got the cuff down. People are accepting the fact that they're not getting that much extra ventilation into the lungs, but that additional pressure might help with the airflow through the vocal cords, and also it might just help with the work of breathing and reduce the amount of resistance in the circuit by adding a little bit of PEEP. Now, if that all sounds like gobbledygook to you, don't worry. The next set of videos will be talking about ventilation, and you'll start to understand a little bit more about how you can use the ventilator to reduce the amount of resistance in the circuit and reduce the amount of work of breathing for patients. Downsizing tracheostomies, as I say, is something that they do to try and improve the amount of space around a tracheostomy. This is especially useful if you want to cap a tracheostomy, because if you do that, you obviously need as big a calibre as possible of the trachea that's free so that the patient can breathe in and out easily through their mouth. And decannulation is something that is usually a combined decision between the consultant or registrar intensivist and the nurses and the physiotherapists who will be working on the chest, looking at the amount of secretions, looking at the amount of ventilatory support that's needed, and looking at the strength of the patient, their ability to take breaths in, generating negative inspiratory pressures, and so on. We'll talk a lot more about decannulation and extubations in later talks. Now, a really important part of this talk is thinking about troubleshooting tracheostomies. Now, I'd really suggest that you go and have a look at the endotracheal tube video that I did before, because this will go through some of the basics of troubleshooting those tubes that are essentially analogous to a tracheostomy. So a cuff leak is usually because the cuff is damaged. So the first visual checks and tactile checks that you can do is by feeling the pilot balloon. If you feel that it's nice and inflated, then it's likely that there's enough air in the tracheostomy. If there's enough air in the tracheostomy, similar to with the endotracheal tube, it might be that the tracheostomies come out a little bit of the trachea. And if it's come out a little bit, you might be getting leak around the larger area of the tissues around the soft tissues around the trachea. So if there's a cuff leak, it's either there's a problem with the cuff or the tracheostomy itself has pulled out a little bit. Obviously, get senior help with both of these issues, because what might need to be done if the cuff is damaged is to change the tracheostomy over to a trachea that doesn't have a damaged cuff. Or if the tracheostomy has come out a little bit, it might need to be advanced in. That's usually best done under direct vision with a bronchoscope, especially if there's lots of false tracks around. Now, an emergency would be a blocked tracheostomy. As I said before, you get a lot of thick crusting of secretions with tracheostomies because there's just less humidification. It's not uncommon for tracheostomies to block off like that with lots of secretions. If this does happen, the first thing to look at is what type of tracheostomy you have. If it's one with an inner cannula, the easiest and first thing to do is to unclip the inner cannula and take it out and replace it with a new one. And that might be all you need to do to get the patient breathing again. If, however, this does not work, the second thing that you should do, and you should always have with you when you have tracheostomies, is suction catheters. Pass a suction catheter through the tracheostomy. It should very easily pass down, and the patient will start to cough when it tickles the carina. This is important because what you're saying is that it's patent and it's going all the way down into the trachea. Because if it's blocked, it might be that there's secretions or something that's blocking the end of the tracheostomy. However, the other option is that it's actually come out of the trachea and it's just sitting in the soft tissue. So if you find it difficult to pass that suction catheter through, it might actually be that it's come out. The other way in which to confirm that a tracheostomy is in or out is by looking at the end tidal carbon dioxide levels. If you see that the end tidal carbon dioxide trace is normal, then it's likely that the tracheostomy is in the trachea. Now again, it might be that it's in, but it's just sitting just at the edge of the tracheostomy site, and therefore you can't pass the suction catheter because it's come out too much and it's just hitting the edge of the hole into the trachea. So in those cases, if you've got an end tidal CO2, it means you can ventilate this patient or at least oxygenate them until you get senior help, and they may put a bronchoscope down through the tracheostomy and see what the problem is. But always remember, suction catheters are your friend with tracheostomies. Now, the thing that people often worry about, especially junior doctors and also nurses, is the dislodged tracheostomy. As I said before, this is important in that you can lose the airway, but you've also got to know what type of tracheostomy they have. Do they have a percutaneous tracheostomy or a surgical or open tracheostomy? If they have a percutaneous tracheostomy, how long ago was it formed? If it was formed less than 2 weeks ago, you need to get something into that hole quickly, otherwise it will close up, and it can close up in a matter of 5 to 10 minutes, even quicker in some cases. So, if you do see that it's come out and they haven't had a laryngectomy, i.e. their upper airways are patent, what you can do is just put a suction catheter down through, leave that, and then give them mask oxygen and cover up the tracheostomy site until you get senior help. By putting the suction catheter down, what you're doing is you're keeping that tract patent, and therefore the next doctor who comes along might be able to actually use that to railroad the tracheostomy over. If the patient has had a laryngectomy, you are not going to be able to oxygenate through the mouth and the nose because they've basically closed off the oropharynx. In these patients, what you need to do is to try and oxygenate them through the tracheostomy side. Now, if you're trained, you might be able to put another tracheostomy in. I would suggest, if you're not trained in putting in tracheostomies, I would not be putting one back in through the hole that's there. I would put a suction catheter in. You're not going to cause any damage or create any false tracts by putting that in because they're flexible tipped. And then I would put some oxygen over the hole. You might need to ventilate them as well. A really great little trick to being able to ventilate over a tracheostomy hole is by taking a laryngeal mask airway. You can either use an LMA, which you can see here, or you can use something called an eye gel. I find the LMA is easier because the cuff you can inflate and deflate so that it forms a good seal around the neck and the whole of the stoma. And then you can slowly bag them, very similar to how you would hold a mask over the patient's face. It works beautifully. We sometimes do it in patients in theatre, and it works really nicely. So if you're finding it difficult to get oxygen in, or you can't get oxygen in through the mouth, you could try using an LMA, occluding over the tracheostomy stoma site, and ventilate through that. And similarly, in patients who've had accidental extubations, they're very drowsy, they're not able to spontaneously breathe for themselves, you might find that by using the LMA you can just ventilate them enough until you've got senior help that comes along and either puts the tracheostomy in or puts an oral and a tracheal tube in. So overall, Actually, if you do have problems with the tracheostomy, the key thing is to go and ask for help. But in terms of things that you can do, very simply, suction catheter and an LMA are the only things you really need. Put a suction catheter down the tracheostomy to make sure it's patent, suction out any secretions that might be there, change the inner cannula if you can, if it's got one, and if all else fails, the tracheostomies come out, put an LMA over it, and you can provide oxygen through that, and if you need to, you can potentially ventilate through that as well. Now, in terms of the emergencies with tracheostomies, it goes through exactly the same sorts of things as before. Check the patency. How do you check a patency? So you've been called to a patient who's had a cardiac arrest, they have a tracheostomy in sight, and you're the only doctor on the unit. So you run over to the patient, they're on the ventilator. So the first thing that you would do is, irrespective of what the cause of the arrest was, I would have a look at the tracheostomy. Remember, it goes A, B, C, D, E. You're assessing your airway. See whether the tracheostomy has an inner cannula. If it does, take out the inner cannula, exchange it for another one. Remember, do not take that inner cannula out until you've got another one to put in there, because you're not going to be able to put any kind of other adjunct like a ventilator tubing or a water circuit onto it if you don't have that inner cannula in. Pass the suction catheter through the tracheostomy. Make sure you can easily pass it all the way down. And then you must always have end-tidal CO2. End-tidal CO2 tells you that the gas coming in and out of the tracheostomy is seeing the lungs. You're getting carbon dioxide exchange, and therefore you're able to oxygenate that patient. If you do have a cardiac arrest, now obviously you're not going to be able to do this, but it's worth you knowing what type of tracheostomy they have, because if they've got an uncuffed tube, whoever comes to the arrest will then need to change that over to a cuffed tube. The reason is that they'll need to bag the patient, and if you've got an uncuffed tube, when you bag them, all of the gas that you try to push in will go through the path of least resistance and come out through the nose and the mouth. If you do have an inner cannula, make sure that it is inserted. If you don't, when the doctor comes to try and put the water circuit onto it, then it's not going to fit. So you must have an inner cannula with any tracheostomy that has an inner cannula as part of its system. If you take out the inner cannula and you find that you haven't got another one, they will always have a like-for-like tracheostomy, brand new, sitting in a box next to the patient. Just open it up and take the inner cannula from that kit. So we've gone through quite a lot about tracheostomies, but I think it's important because it's a subject that even seasoned intensive care doctors have some trepidation about because of the various different permutations of types of tracheostomy. What I hope we've gone through is what a tracheostomy is and why you'd use it, the types of tracheostomy, adjuncts that you use for tracheostomies and why they're used and how they work. A little bit about weaning off a tracheostomy, but we'll go through that in a huge amount of detail in future videos where we'll talk about ventilation and how the patient can be supported with their ventilation, how you bring that support down to a point where they can spontaneously breathe. We've talked about troubleshooting tracheostomies and emergencies in patients with tracheostomies. I've highlighted some of the problems that can happen and some of the key mistakes that some people who are inexperienced make as well. As with all of intensive care, if in doubt, ask. You've got the physiotherapists, you've got the nurses, and you've got the senior intensive care doctors and anaesthetists who are so experienced with tracheostomies, they will always be able to give you some additional help. So never feel afraid to ask for help. Thank you very much. If you've liked this video, please like, subscribe and hit the bell notification so that you can hear when new videos are up, and we'll continue to go through this beginner's guide to intensive care.